So good afternoon, everyone. Welcome to this special edition of the NITheCS Colloquium, which is special for two reasons. One, because it's the last NITheCS Colloquium of the year. And I counted this afternoon how many we had. This is number 44. So we had almost every week last year, or during this year, one colloquium. Yeah? And we will resume then mid-January again next year, yeah, with some other interesting topics. And today it's a very big pleasure to introduce to you Dr. Cari van Schalkwyk. I hope I pronounce your surname more or less right, but you can mispronounce mine freely as well, so no problem there. Yeah? And Cari works at SACEMA, which is the DSI-NRF Center for Excellence in Epidemiological Modeling and Analysis. Cari studied epidemiology and biostatistics at UCT, and she has worked on many projects related to HIV, tuberculosis, COVID, of course, malaria, cervical cancer, and she will speak about this topic today. Cari, we are very happy that you accepted the invitation to share some of your interesting work that also influence some of the official World Health Organization documents. And you already started sharing your first slide. You're most than welcome to start the presentation. And as usual, I always forget to remind the participant to please make use of the Q&A facility to ask questions. Yeah. So thank you very much. Cari, you're most than welcome to start with your presentation.
Okay, thanks, Francesco, and thank you for the invitation. And I also want to say if there's a clarifying question in the middle, please pop it whenever, and Francesco will stop me and ask the question. So, thanks. The WHO has declared that we can eliminate cervical cancer worldwide in the next century, and I'll be showing you some of our findings on the potential for elimination in South Africa. I didn't have much time to prepare for this talk because we have been very busy with Omicron analysis these last 2 weeks. So this talk is a combination of talks that I've recently done for different audiences. And I know that this particular crowd may be more interested in the technical details, which there isn't much of. So sit back for some light entertainment. In a recent talk about modeling during the COVID response, Prof. Sebastian Funk from the London School of Hygiene and Tropical Medicine said, models are tools to combine data. So what we know with theory, what we think to learn about what we don't know. And in the early days of COVID, and now again with Omicron, of course, there's a lot more theory than data. And the apparent wrong of the early models gave epidemiological modeling a slightly bad reputation. But luckily for us, when we model cervical cancer, there's a lot that we do know. The virus that causes this cancer has been around since the Neanderthals, and we have plenty of local data. So we have fewer theories and assumptions, and we can predict the future with some certainty. So just a slight overview. I'll first give you a brief background about the disease and its prevention in South Africa, and then I'll discuss the model that we use for this analysis, and then we'll use this model to estimate the impact of the HIV epidemic, the current screening program, and different proposed vaccination and screening strategies on cervical cancer incidence. So this cancer is caused by the sexually transmitted human papillomavirus, and all cancers are caused by this virus. HPV is very common. Several studies in South Africa found that around 75% of women aged 15 to 25 have oncogenic HPV. But most of these infections will spontaneously clear from the genital tract. And the WHO estimated that around 13,000 new cases occurred in South Africa in 2018 and around 5,500 deaths. This cancer can be prevented using primary and secondary methods. So transmission of the virus can be prevented with condoms. They are about 70% effective, and not 100% because the virus lives on skin cells or epithelial cells. Several vaccines are available that protects against many of the types that cause cancer, and several methods of screening for pre-cancer that can prevent cancer are available. When we talk about cervical cancer in South Africa, we have to discuss HIV. So 20% of adult women in the country live with HIV, and HIV co-infection increases your risk of cervical cancer 6-fold. And ART, so antiretroviral therapy for HIV, reduces the risk compared to those not on ART, but risk is still higher than for HIV negative women. So at the moment in South Africa, girls aged 9 in public schools are vaccinated since 2014, and we have consistently achieved around 80% coverage of the first dose and 60% coverage of the second dose. The vaccine protects against HPV type 16 and 18, which causes around 2/3 of cervical cancer in South Africa. We assume that 1 dose of the bivalent vaccine gives lifelong protection against type 16 and 18. And we have data from the first randomized clinical trials for the vaccine that shows no immune waning after almost 15 years. And screening for pre-cancer is mainly through pap smear, followed by colposcopy, and both of these are diagnostic tests, and then LETS, which is a treatment method. So briefly about the model. The modeling framework that we developed for the study is called microcosm, and we added the HPV and later cervical cancer components to this framework that originally presented only the population dynamics and HIV. So it's an individual-based model with a population that looks similar to the South African population by age, sex, time from 1985 and for the next century. So at weekly time steps, babies are born, people age and die. And we simulate a complex sexual network based on extensive studies of South African data. So from the age of 10, people can form heterosexual relationships. And these relationships can be short-term or long-term. High-risk individuals can have a maximum of 2 relationships at a time, and low-risk will only ever have 1 at a time. And men can have short-term relationships with female sex workers. So we simulate infection with HIV and 13 oncogenic HPV types through sexual contact with an infected partner. We also simulate disease progression of both of these infections. But of course, due to a lack of a cervix, men can only be HPV infected. And then, like I said earlier, HIV status influences HPV natural history, but not the other way around. So HPV doesn't influence HIV at all. The model was calibrated in several steps to research, study, and surveillance data of sexual behavior, HIV prevalence, HPV prevalence, and cervical pre-cancer and cancer. And all the technical details are published in these 3 papers, but I'll show you the approach to one piece of the data, cancer incidence. So what we see here are estimates of age-specific incidence reported to the National Cancer Registry over time. So on the x-axis, we have the year since 2000 up to 2016. That's what we had data for. On the y-axis, we have incidence per 100,000 women per year. And the panels are all ages, and then in 5-year age bands, the incidence of cancer. So cervical cancer is a rare disease with crude diagnosed cervical cancer incidence of around 50 per 100,000 women per year. Since this is an individual-based model, it is expensive in terms of computing time, and even if we simulate the largest feasible population, model results are severely affected by model stochasticity. So you'll struggle to fit these results that are all over the place to the red line, which is the data. To get around this problem, we smooth the time series of incidence estimates by fitting a Poisson regression to the model results. We then calculate likelihood values by assuming that the difference between the log transformed Poisson regression estimate and the log transformed observed incidence is normally distributed. And then we choose 100 parameter combinations with the highest total log likelihoods, so considering other data sources as well, as a sample from the posterior distributions of these parameters. And then we run simulations for each of these 100 parameter combinations and aggregate results to show fits to the data. So this plot shows the model fits to this one piece of the data with the axes flipped around from the previous slide. So now we have years on the panels and age groups on the x-axis. And again, the age-specific diagnosed cervical cancer incidence as reported by the National Cancer Registry are in red. And then the mean of the model is the black line with its 95% uncertainty intervals. So next up, we'll use this epidemiological model to estimate the impact of the following on cervical cancer incidence in South Africa. First, we look at the HIV epidemic, the current screening program, and then we'll look at ways to knock this cancer on its head. So first, I want to explain that the scenario that I call the status quo, which is this black line in this and the next plots. So this is the scenario that was fit to data up to 2016, and in this case, projected up to 2040. We assume that coverage of screening and linkage to treatment will stay the same at 2018 levels. And we see that age standardized incidence has increased in recent years as women with HIV survives longer due to ART and has time to develop cervical cancer. But then we expect to see decreasing trends from 2025 since women start ART earlier and are expected to have a better immune response to HPV. We also show here a counterfactual scenario of a South Africa where HIV never happened. So cervical cancer incidence would have slowly decreased due to screening. The other counterfactual scenario is a South Africa where ART was never widely available. And cervical cancer incidence would have decreased since many women with HIV would have died before developing cervical cancer. So looking at these three curves together, we can conclude that the HIV epidemic has increased cervical cancer over the last 20 years, and that the increases in recent years are due to women with HIV surviving long enough on ART to develop cancer. So next up is the current screening program. So just showing that this is the current screening algorithm that the model simulates. So pap smear screening is followed by the look and let's approach at colposcopy clinics. And probabilities of entering screening, loss to follow-up, screening intervals, and linkage to colposcopy are mostly based on individual level data from the public sector of the Western Cape, but adjusted if other data sources are available. So there are many losses in the system from low coverage of screening, low levels of adequate samples taken. So a very specific area needs to be swabbed, and that sample needs to survive all the way to the lab. Low sensitivity of the pap. So what happens is that the sample is put in a dish and a cytologist looks through the microscope at these cells. So it's a subjective assessment of what's going on. So this method has low sensitivity. And then for those that get the diagnosis of there is abnormalities present, they have to go to colposcopy clinics. So that linkage is low at only 50%. And that also has imperfect diagnostic accuracy, and then also low treatment success of those who do end up at the clinics. So this care cascade shows that on average in the simulation, only about 5 to 10% of women with precancer who went for a pap smear will end up successfully treated. Despite this low coverage of screening and the low fraction of cases successfully treated, we estimate that the screening program has prevented around 8,600 cancer cases in the last 20 years. So the yellow line illustrates the counterfactual scenario where no screening program was ever implemented. Okay, so the third objective is to consider the elimination potential of different strategies. So a brief background about this elimination story. Last year, the WHO published their global strategy to eliminate cervical cancer in the next century. And they define elimination as less than 4 per 100,000 women per year. And their target to achieve this elimination is to reach 90% coverage of the non-valent vaccine. So this is a newer vaccine that covers against more HPV types than the vaccine that is administered in South Africa. It is unfortunately still very expensive, and we haven't even started negotiations to bring that price down in South Africa. The next target is to reach 70% coverage of twice lifetime screening with an HPV DNA test. So the pap smear that we use detects abnormal cells, so precancerous cells, but this test detects the virus itself. So it has very high sensitivity, so it picks up the virus, but unfortunately it has very low specificity. So specificity for precancer. So it will just pick up all virus, and like I said earlier, most of the virus will spontaneously clear. So this test you can only use for older women, because you just can't go and willy-nilly treat everyone who tests positive for HPV DNA, because that's almost everyone at certain ages. So if you use this test, you also need to carefully think about ages. And their recommendation is twice lifetime at age 35 and 45. And then the third target is to treat 90% of all those who test positive for HPV with a 100% effective treatment method. And like I showed earlier, our treatment methods are very far from 100% effective. Okay, so these are their targets, and they came up with these targets using input from mathematical models. So these models showed that in lower middle income countries in all regions of the world, elimination can be achieved if these targets are met by and maintained after 2030. They estimated that in these 41 countries of sub-Saharan Africa, 50 million cases can be averted over the next century. However, their status quo assumption to calculate how many will be averted is that incidence will stay constant if we change nothing. But these models didn't consider HIV at all. Through predicted reductions in HIV only, cervical cancer will decrease in the future, as I've shown in this earlier slide. So therefore, the status quo is not really constant, and the 50 million averted cases is likely an overestimate. Since this paper was published, the WHO has convened a group of modelers to consider HIV in cervical cancer elimination. And our model is one of those, and I'll talk a little bit more about that later. So strategies that we'll consider to see if we can get to elimination in South Africa leans on the targets and technologies that the WHO is proposing. So first, we'll scale up our current program to 90-70-90 from 80-50-50. So that's where we are now with coverage. And next, we'll keep coverage the same, but use different technologies. So these newer, fancier methods. And then we'll use exactly the same assumptions as the WHO Cervical Cancer Elimination Modeling Consortium. So 90-70-90 coverage using the newest technologies. So to compare to the WHO estimate, we also estimate over the next century. And of course, that comes with a lot of assumptions. We are assuming that HIV prevention coverage will stay constant, leading to substantial declines in HIV prevalence. But we assume that sexual behavior will stay the same, and we also make strong assumptions about fertility, mortality, and migration. So note that even for the scenario with no screening program or vaccination, we estimate a decline due to declines in HIV. Our status quo assumes bivalent vaccination coverage will stay constant at 80%, and screening coverage and linkage treatment will stay constant at around 50%. And under this status quo scenario, incidence will decline to 12 per 100,000 women years. And remember, the elimination target is at 4. So with the strategy of 90% bivalent vaccination, 70% coverage of pap smear, and 90% linkage to treatment facilities, we'll get near elimination at 7.3 per 100,000 women in 2120. We'll avert 71,000 cases over the next 20 years and 374,000 cases over the next century. Okay, so next we'll keep our coverage the same, but use the newer technologies. The technology we'll consider are non-valent vaccination and HPV DNA testing with the gene expert assay. And we consider this specific test because these gene expert machines are available at decentralized clinics for TB testing. So we have a lot of these machines, so we can assume that we will be able to use this machine for HPV DNA testing as well. This test can distinguish between infection with types 16, 18, 45 and other oncogenic types or high-risk types. And we assume that those testing positive for 16, 18, 45 will immediately be treated. And those who test positive for the other high-risk types will get either a pap or a colposcopy triage test. Triage just means an extra test before treatment. We see that for both of these triage scenarios, they have almost exactly the same trend, and the differences in sensitivity of the two triage tests are offset by the differences in linkage. So the pap one you can do at the primary healthcare clinic, and the colposcopy triage will also need to be referred to other clinics. So there's always losses involved with referrals. And then adding non-valent vaccination to the new testing method will reduce incidence to 8.3 per 100,000 women in 2120. We'll avert 85,000 cases over the next 20 years and around 300,000 over the next century. So if we assume that we can reach all the targets that the CCEMC set in South Africa, we will reach that elusive elimination threshold of 4 per 100,000 women per year and avert around 443,000 cases over the next century. So getting back to the WHO Cervical Cancer Elimination Modeling Consortium's story, they of course knew that the limitations of ignoring the impact of HIV in sub-Saharan Africa in these elimination models, but very few groups in the world have developed models that consider both HIV and HPV and model the dynamics of the two. And none of these models provide global estimates. So they could identify 3 groups: us, it's microcosm HPV, a Harvard group, and a University of Washington group who were working on such models for South Africa, or KZN in the case of the Washington group. They asked us to consider the same strategies as in the global paper, as well as some strategies focused on women with HIV specifically. So that involves screening 3 early and catch-up vaccination. So we're still writing up this comparative modeling study, but the results from my model show that these additional strategies aimed at women with HIV will lead to further reductions in the medium term. But then after around 2080, 90% of women will be vaccinated. So flowing through, almost everyone will be vaccinated by then. And the additional screening for women with HIV may not be beneficial at the population level anymore. So adding these extra strategies for women with HIV could avert about 74,000 extra cases and more than 500,000 over the next century. So to review these strategies, if we can scale up our current program to 90-70-90, we can avert 374,000 cases over the next century. But due to the increased screening coverage and higher linkage to treatment, referrals to colposcopy clinics will increase by 3-fold compared to the status quo in 2014. So this means that substantial investment in additional colposcopy clinics will have to be made to cope with the increased demand and increased linkage. And also additional staff to handle these increased referrals. For the second strategy, if we use pap smear as the triage method, the entire screening to treatment process can happen at the primary healthcare clinics. So those are the small clinics nearest to a woman's home. And that will, of course, result in fewer losses. And although this plan seems the most feasible, we will still need to do a cost-effectiveness analysis to determine its affordability, because both the non-valent vaccination and the HPV DNA test are still unaffordable or it seems unaffordable in the public sector, but yeah, we'll have to do a proper cost-effectiveness analysis. And then, of course, the WHO's strategy will prevent the most cases and therefore save the most lives, but it raises the most concerns for both the feasibility and the affordability. So in conclusion, our existing program has already prevented thousands of cervical cancer cases. Sustained HIV prevention should lead to declines in cervical cancer in the future. And under ideal circumstances, using the best current technologies, we can eliminate cervical cancer in the next century. And then important next steps are to investigate which strategies and technologies are feasible and affordable to implement. Thank you.
Yeah, Cari, thank you very much. It was a really interesting talk, because these days we hear a lot about COVID, and we seem to forget a little bit about other conditions and problems that we face that also need an urgent solution and some attention and some investigation. I didn't see any questions so far in the Q&A. I think everybody was very focused on listening to your message. But since we are not so many, I would like to encourage the participants maybe to quickly raise their hand, and we can, Ilya and I can immediately give them the right to ask their questions. I see. Here there is one comment by Zurab that the results are impressive. And I don't know if Zurab wants to make a comment in person.
I like those kinds of comments.
Yeah, we can ask him to speak if she so wants. In all of these, Cari, I forgot to ask you at the beginning of the talk, if you had a few minutes after you talk to take part in our post-colloquium chat in Kumo space. I don't know if you have a few minutes. I will quickly post the link in the chat while hopefully people start preparing to ask you a question. I will do it in a second, so I just need to open my browser to find the link.
Hello, can I ask a question?
Please, Stuart.
Hi, Cari. Yeah, so it's really impressive to see these results. And so how does it work? Are you like committed to this work for the next few years, or is it something that's part of your journey and you're planning to move to something else in the future?
No, it's definitely in my plans for the future. I'm working with colleagues at the Western Cape Provincial Data Center to come up with an algorithm to estimate cervical cancer incidence in the Western Cape. So the province has a patient identifier that's unlike the other provinces in the country. They can't link details of patients across systems, but in the Western Cape we can. So we are coming up with the algorithm to properly estimate cervical cancer incidence in the province by HIV status. So that's the one thing. And then the other thing that I'm still busy with is the cost effectiveness analysis, which is slightly more painful because although we have really good data on prevalence of HPV, prevalence of cervical precancer and cervical cancer, we have very little data on mortality. And a cost effectiveness analysis is very focused on mortality. So it's saving lives. How much does it cost to save lives or life years? So I'm still working on getting improved estimates of mortality for that. But yeah, I was hoping to have that done by the end of this year, but then COVID happened. So the boundaries are shifted to end of next year.
Yeah, thank you so much. If I may ask a second question. I feel a bit stupid asking this because you surely addressed this, but I didn't quite understand, I think, how does this analysis for projecting what's going to happen in the future, how does that inform and help with the screening? Because it's the screening that saves lives, right? Do I understand it correctly? So can you maybe repeat one more time how the interaction between projecting the future and the effect of this on screening?
So I talked a lot about coverage of screening. So there are two things. We can not either, the one or the other or both, increase coverage of screening to higher than it currently is, and not only increase the coverage of the screening, but also very important, the linkage to treatment, because that's the real loss at the moment. So these scenarios looked at either increase coverage or start using different methods, which doesn't have that big loss. So we showed that increasing coverage or using different methods leads to almost the same long-term impact. Right. But then, of course, if we can do both, we will reach elimination. But doing both will be very hard and very expensive.
Okay, I understand it better now. Thank you very much. So you basically making projections into the future enables you to have a better strategy in terms of exactly what needs to be done and what kind of increase where and so on. Okay, thank you.
Yeah, but of course, to make recommendations to the policymakers, you need to put money where your mouth is. And so I'm working still on the cost effectiveness analysis. So yeah.
Thank you very much. Thank you.
Sure.
Thank you, Zura, and thank you, Cari, for the answers. I think our audience is not very much in question mode this afternoon, Cari. Then maybe they're looking forward to interact with you in our famous Kumo space that I just posted the link in the chat, which is a way more informal setting and where it's easier to get into a conversation without the formality of Zoom. Yeah, and
Sir Francesco,
Ian?
You posted the link only to the panelists
Oh,
And
sorry.
on the host, can you post it to everyone?
Yes. sorry. My mistake, everyone. Okay. Sorry. Here comes the link again. Here we go. Sorry. That was the chat, the setting of the chat as they were. Sorry, I didn't pay attention. Thank you, Ilya, for picking that up. Yeah. So no, it's very simple. You just click. If you have never been in Kumo Space before, you quickly have to register using some email address that of your choice. Yeah. Okay. Then Cari, thank you so much for sharing with us these very nice insights that I think it is necessary that we share with everybody, because, as I said before, COVID covered many other problems that are still there, and we still need to solve. So thank you very much for being with us. We will send you tomorrow the link to your talk as soon as we have uploaded it in YouTube. And if you have time, we are looking forward to chat with you in a more informal setting in a few minutes in another environment.
Sure.
So thank you very much, everyone. Thank you for being with us. Thank you to everyone. Thank you to those of you who followed us the whole year. And I hope you will keep doing that next year. And I will see hopefully some of you just now in Kumo Space. So thank you very much. Have a good afternoon and all the best for the festive season and a happy new year. Yeah, thank you. Thank you very much, Cari. Thank you. Bye bye.